So, on behalf of the BC Brain Wellness Program, I am really happy to introduce Dr. Fidel Vila-Rodriguez, who will speak to us today about apathy, depression, and anxiety in the care recipient, and how the care partner might be able to support those people with those experiences. Depending on timing, hopefully we'll have a few minutes for questions before he has to leave. And following his talk, I'm going to share some thoughts on the experience of joy as it can live side by side some of these challenges that you're dealing with on a daily basis. So Dr. Vila-Rodriguez is an assistant professor in the Department of Psychiatry at the University of British Columbia and the director of the Non-Invasive Neurostimulation Therapies Laboratory and Schizophrenia Program. As a clinical scientist, he has a strong interest in conducting translational research that bridges neurobiology of psychiatric disorders with clinical applications. His clinical practice is actively focused in those who are most severely affected, and his research interests are directed at finding new therapeutic interventions that can help mitigate suffering of those with severe and refractory forms of psychosis and depression. And with that, welcome, Dr. Vila-Rodriguez.
Thanks so much, Elaine, for the kind introduction, and good morning, everybody. I'm joining as well from the Center for Brain Health and actually the space at the Parkinson's Clinic, where I've been working for, I think, the last 7-8 years as a consultant psychiatrist. And what I'd like to share today are actually a lot of things that I've learned from folks like yourselves who look after people with Parkinson's and from people with Parkinson's. So I'll try to blend both science and the pearls of wisdom that I've learned from you. And so hopefully that will set the tone for questions that you might have. And I'm always mindful that in these events, reaching out to people who are directly affected by this condition is really important, to have lots of time for questions. So I have made an effort to be lean on the slides. They'll have content that I hope sparks discussion, and hopefully we'll have a good 20-minute period of time for questions. I'm gonna start sharing my screen, and be mindful that I'm gonna minimize the view here, so I'm not gonna be able to see any of you. But I'm just gonna hope to get a bit of feedback in terms of, number one, can people see the slides?
Yes, it's perfect.
Perfect. And does my sound come through all right?
Also good.
Perfect. All right. As Elaine mentioned, you'll have the slides. The session is going to be recorded, so you're going to be able to go back to my disclosures. I don't have actually much in terms of conflicts of interest and related to Parkinson's Clinic or the work that I do related to Parkinson's. If anything, the lab has had in-kind equipment for investigator-initiated research from this company called MacVenture. But that's the extent of it. I'm gonna divide the talk in 3 main areas. The first one is to touch on the idea of Parkinson's disease as a brain network, and we'll see how that differs from the more traditional, or how the understanding of Parkinson's was decades ago, and how it's shifting now, so that we can appreciate how it makes a lot of sense that symptoms like anxiety, like apathy, and other symptoms that are not directly motor symptoms can appear in the context of this condition. We then will talk about that challenging sometimes kind of distinction between what are reactions to the diagnosis of such a kind of serious condition that can be understandable and to a certain extent, I'm going to use the word normal or expected, to what are symptoms that tell us that there's something beyond that reaction to such an important diagnosis. So how to distinguish when we believe that there's a depressive disorder or an anxiety disorder versus when it's just a transient reaction. And last but not least, and I think it's particularly relevant for this group, understanding a little bit and giving some context about the differences in how the medications for the motor symptoms of Parkinson's differ in terms of the timing of its effects compared to medications to treat depression or anxiety. And before I go into the context, into the content, I'd like to start with this slide. And perhaps most of you are familiar with some variation of this slide. But what it shows is the biopsychosocial model of illness. And you can see the reference here was a very impactful paper back in 1977. And what this work kind of put forward is the idea that any medical condition, anyone, can be best understood if we take into account that there are several layers to kind of make the whole illness. And there's at the bottom the level of the biology, right? It's like, what are our genes in the context of Parkinson's? What genes might make people more propense to suffer from Parkinson's? What are the changes in the brain that lead to the symptoms? But there's also another level, which is more at the psychological level, which is how do we react to a diagnosis of a serious condition, and how that reaction can have an impact going down to our biology. And we are also mindful that there are social factors that have a huge impact on determinants of health. It might be more of an indirect kind of connection, right? Or environment or circumstances have an impact on our psychological well-being, and that in turn can have an impact on our biology. But we are also, in the context of Parkinson's, for example, we know that there are social situations that expose people sometimes to pollutants and to risk factors that can affect and go down to biology. So this is the model that I operate in. And if in the talk now moving forward, I go down to a lot to the biological level, is only because that's going to be the focus for today's talk. But I think it's important that we all keep in mind that it operates in this global context. And we'll touch a little bit how these two levels, the psychological and the biological, can interact and influence each other. So Parkinson's disease as a brain network illness. What do I mean by that? By that, I mean that when Parkinson's disease was first described, the model that was adopted is this model that shows the area of the brain, the substantia nigra, where the dopamine neurons are, and give this black color here. When these cells, brain cells, are affected and progressively die, we see a loss of pigmentation, and the absence or lacking these cells here leads to affecting the dopamine motor circuits. So you've heard about the basal ganglia. And the diagram here is intentionally very complicated. That's just to say that this particular and very well-defined neuropathology or lesion in the brain leads to dysfunction of the motor systems, and that makes it express in the very classic and traditional motor symptoms: tremors or shakes, rigidity, and bradycardia, which is a word that describes the decrease and slowness in movement. That was how Parkinson's disease was initially described, and how the Parkinson's Medications Act, they try to compensate for that deficit in dopamine in this brain circuits for motor function, and they treat the tremors, the rigidity, the bradycardia, gait. However, neurologists and people working in Parkinson's field realized that there are a number of other non-motor symptoms. And over time, the appreciation for those non-motor symptoms has grown a great deal. And they call it now non-motor syndrome. And this is an image of, and this comes from an MRI scan to show an image of the brain and different areas of the brain that can be affected in the context of Parkinson and lead to other non-motor symptoms. And we have the whole range of symptoms, from fatigue, apathy, problems with sleep, pain, depression, anxiety, you name it. And the key and core idea here is that if I were to point with my arrow where the substantia nigra is, it would be kind of down here in the bottom. And the basal ganglia would be deep in that area. And that would be the motor circuit. The core idea here, which is really important, is that when a part of the brain, as important as substantia nigra, is affected, eventually that will cause upstream effects in other areas of the brain. And that's because the brain is a massive network of brain circuits, of cells in different parts of the brain that are connected to each other. Think about any ability that we have. Think about me talking right now and presenting. My brain is able to put together the areas of the brain that work with memory, bring the content, help me articulate language, and express this to you. My presenting now is the result, and being able to do this is all the parts of the brain to work together in a very fine-tuned, orchestrated way. If my substantia nigra, the dopamine cells, were profoundly affected at some point, this ability would be affected. And that's a core idea here. We're moving from an understanding of Parkinson's disease only as a motor illness to an illness that eventually can affect other parts of the brain indirectly and bring up other symptoms in addition to the motor symptoms. This is really important because when I see people in clinic, the key idea to bring up here is that when people present with other symptoms that are not motor, the key idea is that those are also part of Parkinson's disease. It is not that we have a separate illness. What happens here is that we have one illness that eventually leads to the brain not working well and presenting with other symptom domains. So that is a core idea, very powerful and very important to appreciate. All right, let's transition to the many times challenging distinction between what are human normal feelings and what in psychiatry we ascertain as symptoms, and the distinction between adjusting to a serious condition and a psychiatric disorder. Again, this can be challenging because many times the expression of symptoms and feelings are very similar. But for didactic purposes, in this figure, I'm pretending that there's a clear boundary, a clear distinction. Just for didactic purposes. In real life, this is very tenuous and things can get confounded. But we consider that there are certain expressions of psychopathology, of symptoms in psychiatry that can be ascribed as symptoms that belong to mental illness. In the context of, for example, bipolar disorder, we talk that there's elation, that they can be a mania. In the context of depressive disorders, we talk about a depressed mood. In the context of psychosis, we talk about delusions, false beliefs that are held despite reality check telling otherwise. And we also talk about anxiety. On the other hand, we all as human beings experience happiness, we can experience sadness. We sometimes are worried about stuff that happens in our life or get nervous about things. The feelings per se are not a manifestation of an illness. But again, you can appreciate that sometimes distinguishing, okay, when is someone nervous and kind of it's proportional or expected to what's happening around them? And when do we call that, no, this is anxiety, this is a manifestation of something else, a medical condition going on? That can be tricky. But the same way that neurologists are able to make a diagnosis of Parkinson's based on the expression of symptoms, psychiatrists, we get trained to be able to make those distinctions. And the self-report of people and their caregivers about what they are experiencing, it's highly reliable to make those distinctions most of the time. So I think the key message here is that as a psychiatrist, as a professional, it's very important for me to listen and to hear what both the person struggling with Parkinson's and their caregivers observe. And that information is what I take in to make and to help me make that distinction and the diagnosis. The same way that neurologists do with motor symptoms. But it can be challenging. Now, this is an excellent figure. It's really busy, but I really like it. And again, you have the reference here. What this figure shows you is on this bottom is time. And as we move to the right, time goes and moves forward. And on this vertical line, we see the level of functioning. And what happens in the context of Parkinson's is that the illness or the process that leads to the expression of the motor symptoms seems to be at play for quite a bit of time before the onset. So there's loss of those dopamine neurons for quite some time. And it's only when it reaches a certain threshold point when we start seeing some motor dysfunction, It's this red line here, right? And many times there's a delay between the onset of subtle motor symptoms and the diagnosis. And many times, before a formal diagnosis is made of Parkinson's, people struggle with a number of different symptoms that are non-motor. I want to draw your attention to things like depression. That can be a heralding symptom. It can be something that happens years before the formal diagnosis of Parkinson's, but it's related to the loss of dopamine cells. Other symptoms like constipation and then fatigue, sometimes a bit of apathy or pain can happen also before the formal diagnosis and before the onset of the motor symptoms. Once the motor symptoms are there and obvious and diagnosis is made, then everything becomes clearer, right? Is okay, this is what's happening. And when we look back in time and we get the diagnosis of Parkinson's, is okay, now I understand what was happening, why we were struggling with depression, constipation, the fatigue, what were those changes? That's one of the reasons why we can distinguish what is an adjustment situation to the diagnosis versus a disorder. Many times it's very obvious that the person with Parkinson's has been struggling with depression before the diagnosis. And therefore, the diagnosis can add on a layer. Remember the biopsychosocial model? The diagnosis here is acting at the level of the psychological level. It's another hit that affects the biology, which is already affected by the loss of dopamine neurons and manifesting as an illness. So there you have a connection. Indeed, receiving a diagnosis of Parkinson's as a serious illness is a major psychological hit. It's bound to have an impact. If you're already struggling with depression, it's gonna make that worse. If there's not a diagnosis of depression, it might be that, we see a little bit of feelings of sadness, preoccupation about the future, but there's not an overt situation of depression. Maybe there are people with Parkinson's who don't struggle with depression to begin with, and when they receive the diagnosis, they go through a period of time which is limited many times in the severity and the extent of it around the time they receive a diagnosis of Parkinson's. So that's how we, as psychiatrists, we make those judgment calls. And sometimes this requires a little bit of time, right? If I see someone who was just diagnosed with Parkinson's, it's very challenging for me to tease out if there's no past history of depression as to whether that is an adjustment situation or it's also of something more in keeping with a depressive disorder. Sometimes I need a little bit of time, a couple of months, and see if that adjustment kind of follows its course and the symptoms go away, or whether it takes a life of its own, and the depressive symptoms extend to more areas, and then it becomes a diagnosis. It can be challenging, but we can reliably figure it out, same way as neurologists with symptoms, with motor symptoms. All right, last part, medications and the timing of the effect. This is my last slide before the discussion. And just to, first of all, summarize what I've been discussing so far, the idea that Parkinson's is associated with non-motor symptoms very, very often. The estimation is that around 50% of people with Parkinson's will have depressive symptoms either before or during after the diagnosis of Parkinson's and will meet the criteria for depressive disorder. Anxiety is also extremely common. And anxiety is an interesting one because what I've learned working in the clinic is that anxiety and some of the motor symptoms, particularly the tremors, seem to be bind together as if they were two sides of the same coin, in that things that trigger anxiety and bring up anxiety can then worsen the tremors. And situations when the tremors worsen then can be present with a flare-up of anxiety symptoms. Remember what I said about the brain as a network? It turns out that those dopamine cells in that area of the brain, the substantia nigra, and in the surrounding area, have a strong link to areas of the brain that modulate and that can lead to anxiety. So it's the Parkinson's, and both are two sides of the same coin. I'm just going to digress for one more minute on this point and say that with the neurosurgeons at Vancouver General Hospital, we are now looking at this very question. We're looking at the charts and looking at what were the effects of the brain surgery on anxiety symptoms. And so we are very interested in see that connection. And there are other treatment modalities that can help as well, both anxiety and motor symptoms. So I'll stop the digression there and I'll move to that very last point about medications. And this was something that another thing that I learned listening to people with Parkinson's and their caregivers. It struck me all the time that the Parkinson's medications, the medications that deal with the motor symptoms, have an immediate effect, or it just doesn't take a lot of time. It's within minutes that the person notices that they've taken the medication and whether it's helping or not. That's amazing because it gives the person a very easy way to gauge whether the medications are doing its effect. And it's a luxury, as I envy a lot the neurologists, because they have that ability. They can ask and learn whether after taking the medications, the symptoms improve. And there's a very obvious kind of symptom expression. That means that what I learned is that people with Parkinson's get used to the idea that, well, if I take a medication, I expect that if it works, I'm going to notice something right away. And that is not the case with medications for depression or anxiety. And it's what happens as well when we treat depression and anxiety outside of Parkinson's. The medications most of the times do not have an immediate effect. So you take it and you might not notice anything right away or for a few days after taking the medication. So that is a very important concept. Whenever we use medication treatments for anxiety or depression, what we need to gauge is a period of time. And the other key to gauge whether the treatments are helping or not is to take a period of time and see where the trend is going. By that, I mean that anxiety and depression symptoms and apathy always present as fluctuations. It's not that many times are present all the time and they just go down and stay steady or go up and are all the time up. Most of the time, the majority of times, they fluctuate. And that makes it challenging for people to gauge, okay, is that fluctuation because of certain stressors, external, or is it because of the medications for Parkinson's that the anxiety and depression fluctuate? It makes it challenging. And that's why it's very important to make note of an extended period of time and see whether those fluctuations are trending up or whether those fluctuations are trending down, even if there are times when still there's hints of anxiety or low mood. And yeah, I'll wrap it up here and move to the discussion. I'm glad that I was able to deliver the 20-minute discussion that I promised at the very beginning. Thanks so much for your attention.
Well, with that, I am mindful of the time, and I do really want to thank you, Fidel, for taking time out of your day and meeting with us and addressing these important issues. And I think you've given us a lot of more conversation. So we'll have the follow-up conversation in 2 weeks' time with Jean Ward, because next Monday is the holiday Monday. But I think that you've set a stage for a lot of conversation that many people are experiencing. And so thank you.
Not a problem. Thanks for the invitation. Very nice meeting you all, and a pleasure to be here today. Take good care.
Bye now.
Bye for now.